Good morning, ladies and gentlemen. Welcome to the SAARC Surgical Care Society Oration for the year 2023. I kindly invite you all to stand for the ceremonial procession. Professor M.D. Lamawansa, outgoing President of the SAARC Surgical Care Society, Professor Bhavantha Gamage, Secretary General of the SAARC Surgical Care Society, Professor Pramodh Chandrasinghe, SAARC Orator of the Day, Dr. Sunil Kumar Sharma Dakal, President of the Associations of the Surgeons of Nepal. Please take your seats. The SAARC Surgical Care Society was conceived in the year 1994 with the aim of creating a forum for surgeons to maximize the enormous surgical knowledge, experience, and talent of the South Asian region. Following this, the first meeting was held in Kandy, Sri Lanka in the year 1996. Fast forward to today, the SAARC presidency has been held by Sri Lanka for the last 3 years, and now the presidency is to be handed over to Nepal. Therefore, I now cordially invite Professor M.D. Lamawansa to introduce the incoming president of the SAARC Surgical Care Society.
Thank you very much, and good morning to all of you. Thanks to the Senior Most Surgeon of Sri Lanka, currently Professor Alvi Harris initiatives, and between 92 and 96 and those 3 or 4 years, after a lot of meetings and the discussions, and the SAARC Surgical Care Society was established with the aim of improving collaboration among SAARC countries in relation to surgical education, training, networking, and for the purpose of improving surgical care among our country, our patients. SAARC Surgical Care Society since then has been organizing various activities related to the academic and training, and we are happy to see that such activities has escalated over the last 10 years or so. And all the 8 countries are being contributed at the moment for the well-being of the SAARC Surgical Care Society among them. And we must mention the College of Surgeons of Sri Lanka spearheads and also funded the establishment of the SAARC Surgical Care Society headquarters, which is located at Rajagiriya. And Dr. Narendra Pinto is the Director General and who helped establish this SAARC Surgical Care Society headquarters. Among the many activities, the symposia, the lectures, the orations, SAARC Icon of Surgery, to name a few. And also research sessions, paper sessions dedicated to the SAARC Surgical Care Society were held at several meetings that we had in different countries, and they were very popular as well. For the administrative structure, the president rotates every 2 years or so, and we were to hand over the presidency to Pakistan, but there were problems, so we couldn't do it for last 1 year, and the Pakistan after COVID had its own problems. Secretary General comes from Sri Lanka, always, because the headquarters is here. And Professor Bhavanta Gamage, outgoing secretary, has helped the SAARC Surgical Care Society and me in numerous ways to upkeep its activities. So Dulanta Silva will take over at the end of the meeting today. To introduce Professor Sunil Sharma, he was born with surgical hands for the reason that his father was the first surgeon in Nepal. Before 1961, they had just doctors, and any patients who required serious surgical intervention except for incision and drainage of abscesses and suturing had to go to one of the 2 or 3 places in northern India and Patna, and from the border it takes about 300 kilometers to Patna, but to reach the border it takes some time and several days. And his father was the surgeon to the king as well. And Sunil was educated initially in Kathmandu, and they went to Chennai to complete his MBBS, and after that he went to the UK and completed his FRCS Edin, and then came back to Nepal, where he serves as a very senior and talented surgeon in laparoscopic surgery, upper GI, and also oncology, for which he had additional training in Singapore and also in Korea. And he was the principal of the Kathmandu Nepal Medical College, and as professor of surgery there. Now he is totally working in the private sector, and he's a very busy clinician. And he has conducted many training programs, and he could be considered as a father figure in laparoscopic surgery in Nepal. He was well trained in the UK during 1995, 96, that period when the laparoscopy was still in initial phases there. And trauma being a very important aspect in Nepal, and he introduced the primary trauma care concepts. And at present time, he is working on clinical governance and improving the patient care. And of course, he is currently the president of the Society of Surgeons of Nepal. And he is the second Nepali surgeon taking over the presidency. Earlier, it was Rakesh Varma, and who did a Yemen service to the SAARC Surgical Care Society. And it is my honor and pleasure now to hand over the presidency to Professor Sunil Sharma, and from the bottom of my heart, and I wish you the very best, and also SAARC Surgical Care Society. And Sunil.
Mr. President of the Sri Lankan College, friends, ladies and gentlemen. The SAARC Surgical Care Society is a society for not only the surgeons, but to be an exemplary society for this part of the world, to show our unity and for the better care of our people in this area. Now, Sri Lanka has always played a big role in establishing this society, and with the headquarters in Sri Lanka, I think its role in continuing surgical care for this part of the world will grow. However, I must thank the seniors in this region for trusting me with this Herculean task. I know that there is a lot to be achieved. I know there are political hurdles, but as I always keep saying, we are all the same. We're all one. And it is for the betterment of our people that we have all got to learn to work together. With this, I humbly request you to advise and help me in taking this tenure forward, and I will see that I will try my level best to bring the Surgical Care Society forward and make sure that it benefits all the people of our region. Thank you very much.
Thank you, sir. I now cordially invite Dr. Janindra Varsavitarna, Consultant Colorectal Surgeon of St. Mark's Hospital, London, to introduce the orator for the day.
Thank you very much, and welcome everybody. As you see, the theme of this entire meeting is training the future surgeon. And it gives me no greater pride than standing here to actually give the citation for someone that I have trained, and watching his success over the last few years and before gives me fantastic emotional pride to watch as a mentor how we can make a difference as well. So I will start my introduction of Pramodh Chandrasinghe really with my personal pride in his success and achievement. So Pramodh first was introduced to me by Professor Kamaldeen and asked me whether I would take him on in St. Mark's Hospital as a clinical fellow, and I think that was in I'll come back to that. But anyway, he then came and was a clinical fellow at St. Mark's Hospital, and then subsequently got the Commonwealth Scholarship, and then became a PhD fellow at both St. Mark's and Imperial College, and did some amazing stuff. But his achievements go well before that. Even before his PhD and even before his Doctor of Medicine here in Colombo, he achieved multiple gold medals in his university achievements as well. He's, of course, the fellow of the Royal College of Surgeons. He has his MRCS. He's a member of the College of Surgeons of Sri Lanka. And I think one of his great achievements was also to get a Commonwealth Scholarship Award, because that's actually not an easy job to do, and it takes a significant process to actually achieve. Of course, you knew this was going to happen when you look through his CV and you see that he's had multiple awards going along the way. But actually, it takes a certain individual to achieve these things, and in my time dealing with him, I have always been immensely proud of the way his thinking works. Because remember that if we are to be the surgeons of the future, and if we are to take this country and the whole world forward, we have to have a forward way of thinking and a forward way of looking at the way life is achieved. And Pramodh is certainly unbelievably capable of looking one step forward. We had multiple achievements in terms of publications, and even in his achievement here as well. Together at his level, he's reached 62 publications, which I can assure you that when I was his age, I did not have 62 publications. So that's a significant achievement in peer-reviewed journals. 2 book chapters and multiple presentations nationally and internationally. So, ladies and gentlemen, here's a gentleman who has significantly achieved, and I would probably say will be a significant limelight here in taking both Sri Lankan and regional and worldwide surgery forward, and I look forward to hearing his citation today. He also comes with much appreciation from the entire team at St. Mark's, who sends his best wishes to him. Please, Pramodh.
Ladies and gentlemen, Let me now invite Professor Nandadeva Samarsekara to present the SAARC Oration Medal to Professor Pramodh Chandrasinghe.
Good morning, ladies and gentlemen, and thank you, Mr. Barasavitana, for those kind words. Quality improvement in colorectal cancer care, marching towards homegrown data. Carcinoma of the rectum is one of the oldest histopathologically proven tumors in humans. David and Zimmerman in 2010 reported the first ever histologically proven ancient tumor in an Egyptian mummy which lived 400 AD. And Aldred Worthin, for the first time in 1895, came across a woman with colorectal cancer who had a family history of endometrial and gastric carcinomas, suggesting the genetic predisposition in this disease. Around 80 to 85% of colorectal cancers are sporadic, and 15 to 20% are currently considered as familial. But this proportion keeps on growing as we understand more and more about the tumor biology and genetics. The covering epithelium of the colon undergoes proliferation abnormally to cause a polyp in which sequential genetic mutations give rise to a change in the types of cells, leading to dysplasia. And dysplasia with further mutations causes cancer. There are inflammatory conditions such as ulcerative colitis and Crohn's disease, which increases the preponderance to develop colorectal cancer. It is important to discuss colorectal cancer for several reasons. Number one, it is common. Number two, it has a detectable early stage, by which we could prevent the cancer. And also, it is a cancer which is sensitive to treatment, both surgical and medical. Currently, colorectal cancer has the third highest incidence globally, according to Globocan data 2020. And it is the second leading cause of death from cancer. In Sri Lanka, colorectal cancer is the third commonest cancer among both sexes. And more importantly, the incidence has been rising over the past 1.5 decades. The evolution of management of colorectal cancer is a spitting example of transition from eminence to evidence. From the time Morgani described the possibility of anatomical resection of the rectum because we did not know how to, up to Angelita Harbergamma describing the possibility of organ preservation because we know why not to. The colorectal cancer management has made improvements in leaps and bounds. There are few landmarks along this way, but the most important fact is that the mortality has been reducing throughout history. From a disease once had a mortality of almost 100%, we have come to a position where we address even metastatic disease with a curative intent. Clinical medicine is an art of pattern recognition. What we do in our daily practice is gather data, recognize a pattern, and use that information to make decisions. From Florence Nightingale's audit to James Lind's Curvy trial, up to modern-day machine learning and development of algorithms leading to artificial intelligence, the crux is in pattern recognition. Ladies and gentlemen, for the next few minutes, I will take you through our attempts at North Colombo to develop some locally applicable data in changing the management of colorectal cancer. Our attempts at developing a prognostic indicator for rectal cancer, our attempts at describing how rectal cancers respond to neoadjuvant treatment, specimen quality and nodal harvest and its relation to survival, and also how the survival in a Sri Lankan cohort has changed over time. I will be spotlighting on the importance of prospective data collection throughout. The perioperative management at North Colombo is under a unit protocol which encompasses the principles of multidisciplinary team management and enhanced recovery after surgery. Histopathologically diagnosed cancers with total colonic assessment undergo staging with either contrast CT or MRI as indicated. Since 2015, we have been adopting MRI scans for all our rectal cancers, and from 2019 onwards, all our patients with rectal cancer undergo MRI staging. Surgery is performed by the team at University Surgical Unit who have been trained under a common pedagogue. The histopathology assessment is done by the same university laboratory, again led by the same team for the last 2.5 decades. All patients are entered into a prospective database and followed up at the clinic with 3 monthly visits in the first 2 years and 6 monthly visits at the next 3 years and annually thereafter, with ultrasonography and carcinoembryonic antigen levels. A CT scan and a full colonoscopy is done at 18 to 24 months for surveillance. We have also adopted principles of rehabilitation since the past, but since 2019, we have included it in the unit protocol with chest physiotherapy, high protein diet, and physical exercise as indicated. And selected patients will receive cardiopulmonary exercise testing to assess their risk. A prognostic biomarker is a clinical measure that is used to help elicit an individual patient's risk of a future outcome from a disease. Now, tumor tissue, circulating tumor DNA, serum proteins, and fecal proteins have all been tried in colorectal cancer. A prognostic marker allows us to risk stratify patients for surveillance, specific treatment, counseling, and to group them for research purposes. Markers such as carcinoembryonic antigen and carbohydrate antigen 19.9 were extensively investigated in the past. In the pre-1990s, CEA was considered a very reliable predictor of outcome from colorectal cancer. But post-1990 results, with more in-depth analysis, the evidence indicates that both CEA and CA 19.9 are not very predictive of the outcome, especially in stages 2 and 3, where a prognostic marker is very important. And also, they did not have a significant effect on the outcome from colorectal cancer surgery. Also for this region, another matter to consider is the cost. A CEA would cost about $20 in the private sector, and a CA 19.9 will cost about $60 at present. Albumin was traditionally considered a marker of nutrition, and not so anymore. It was included in the Glasgow Prognostic Score and was shown to correlate with outcomes in colorectal cancer. However, Proctor and colleagues who proposed the Glasgow Prognostic Score also pointed out that it may not be a marker of nutrition, but a marker of systemic inflammation. There were studies in the past done to indicate the value of serum albumin as a prognostic marker in colon cancers. And also, a lot of authors tried to draw a line between systemic inflammatory response and the level of albumin. In this backdrop, we looked at 226 patients operated at North Colombo with curative intent. We did not consider a value which was recorded as normal at that time, but we looked at serially ascending albumin values in increments of 5 grams per liter to arrive at a level which has the highest significance in survival. It was 35 grams per liter. And the overall survival in this population was significantly improved when they had a 35 grams per liter of albumin, both the 5-year overall and the 5-year disease-free survival. We looked whether there are other confounding factors that may influence the outcome in this cohort of patients. And we came across that tumor stage, circumferential margin positivity, perineural angioinvasion, and lymphovascular invasion were also significant in a univariable analysis. We carried out two-way interaction terms for the significant factors affecting survival in this cohort, and using a Weibull hazard model, we proved that serum albumin remained an independent predictor of both overall and disease-free survival in rectal cancer. There were many studies looking at lower GI cancers and albumin before us and after us, and Naza et al. In 2015 indicated in their review that this was the first study looking at albumin's long-term prognostic value in rectal cancers, because we know that rectal and colon cancers behave differently to each other. The study was featured in Medscape at that time as the first of its kind. And more importantly, we have described a freely available serum marker that could give long-term prognostic value in rectal cancer surgery. The average cost for a serum albumin level is about $1 to $3 in the private sector and less than half a dollar in the government sector. In the evolution of the management of colorectal cancer, if you ask me, there are 4 landmarks that have significantly made an impact. The recognition of lymphatic drainage by Ernest Miles in 1908 and suggestion of cylindrical excision, the APR. Advent of neoadjuvant chemoradiotherapy in the late 80s. Perfection of the surgical technique by Bill Heald in the 80s. And the proposal of organ preservation by Angelita Abagama in the 2000s. Neoadjuvant chemoradiotherapy has had a significant impact on outcome from rectal cancers. Both the Dutch and the Swedish colorectal studies showed more than 50% improvement in local recurrence rates in patients with rectal cancer. Now, Sri Lanka, as other countries in the SAARC region, has limited access to radiation therapy. There were 6 centers in 2018, reported by Gunasekar and colleagues, and 7 centers with radiation facility by 2021, reported by Jayaraja and colleagues. There were 4 linear accelerators in function in 2020, according to Balavadan and colleagues, and up to 7 linear accelerators by 2022. There are currently 10 functioning linear accelerators, including both private and public sector, with 0.93 megavoltage machines per million people. In some cities in Europe, there are 4 to 5 megavoltage machines per million people. And Vijayaratna and colleagues, in their paper, indicated that only 50% of indicated patients with colorectal cancer or rectal cancer receive neoadjuvant treatment. In this backdrop, we looked at 153 locally advanced rectal cancers. 136 patients who underwent sphincter-preserving surgery were included in the study. Neoadjuvant chemoradiotherapy was delivered in 25 fractions to a total of 5,000 gray, with induction chemotherapy with 5-fluorouracil. The median waiting time for our patients was 10 weeks, ranging from 8 to 11. The sphincter preservation rate was 89%, and the pathological grading of tumor was done using Mandat et al. 1994 description. We demonstrated that a majority of Sri Lankan patients with rectal cancer, 55.8% to be exact, demonstrates a good response histopathologically for neoadjuvant chemoradiotherapy. And only 21% had a poor response. And also a good tumor response was associated with a lower end stage in these specimens. Now, just a good response to radiotherapy means that the patients are doing better. We compared the overall and the local recurrence-free survival of these patients among different tumor regression grades. There was no statistically significant difference in the survival based on the tumor regression grades among these patients. However, the publication of this study also brought out some important figures in the local setting. That is, our anastomotic leak rate from a Sri Lankan center is about 3% for this specific group of patients with low and middle rectal cancer receiving neoadjuvant treatment. It was in par with studies published from the UK and other countries in the West. The local recurrence rate was 6.8% for this specific group, which has a very high risk of local recurrence. And it was also in par with the numbers of the Swedish and the Dutch colorectal trial as well. With that advent of novel modalities of radiotherapy, we do see patients having complete and near complete clinical response these days. And these patients are managed at North Colombo with either close observation or scar excision, which is a new paradigm that we will have to face in the future. Lymph node drainage is one of the most important factors in colorectal cancer. Recognizing the pattern of lymphatic drainage of the rectum allowed Ernest Miles in 1908 to suggest his cylindrical excision or the abdominoperineal resection, which revolutionized the management of rectal cancer. The lymphatic system consists of vessels and nodes, the nodes which act as an immune checkpoint. And when a tumor starts to metastasize, they usually do it either through the blood or the lymphatics. And the presence of tumor deposits in a lymph node will indicate that the tumor has started to spread. Thereby, indirectly, we assume that there might be microscopic mets in other places like the lung or the liver. And Cuthbert-Duke made an advancement for this understanding and included it in his staging system as advanced stage or Duke stage C in 1932. Now, the number of lymph nodes with tumor deposits is the principal determinant of postoperative chemotherapy in these patients. If a patient has lymph nodes with tumor deposits, it is a clear indicator that he will need adjuvant chemotherapy to prevent recurrences in distant sites. The current guidelines recommend minimum of 12 lymph nodes to be extracted for accurate staging. However, the evidence behind this number, the magic number of 12, is not very clear. Not many people know that it came from only 3 studies, population-based cancer registry studies, and 2 of which only looked at stage 2, and only 1 study based on the Swedish colorectal registry was done on both stages 2 and 3. Now, the importance of this is if you classify a patient properly into stage 3, they should receive the benefit of chemotherapy, thereby increasing their chances of survival. And if you accurately stage a patient as stage 2, their disease is of low risk of recurrence, and they should also show better outcome. But only 1 of these studies used both stages 2 and 3, and the number 12 was arbitrarily reached, probably because a dozen was very popular. We looked at 131 patients with stage 2 and 3 colorectal cancer with a minimum follow-up of 36 months to exclude any bias. Patients who had only 5 or more lymph nodes were included in the study. The median nodal harvest for our population for stage 2 was 10, and for stage 3, it was 11. We did not take a magical number as 12 or 15 as the cutoff mark, but we looked at serially ascending values of lymph nodes to achieve at the highest sensitivity to describe a difference between survival. And the number for our population was 14. We looked at the overall survival in stage 2 and 3 colorectal cancers based on the number of nodes harvested, and it was significant when it was greater than 14. For both stage 2 and stage 3 cancers separately, the survival benefit was significant. We did an initial multivariable analysis to look at other confounding factors which might affect the survival in this cohort. And apart from the lymph node harvest, advancing age, male sex, and the lymphovascular invasion were considered as significant. So we did a Cox regression analysis with stepwise selection to ascertain that lymph node harvest of more than 14 remained significant when even adjusted for other factors. Another feature in this population is that nodal harvest is significantly affected by neoadjuvant chemoradiotherapy. It was 8 for those who received neoadjuvant chemoradiotherapy against 11 for those who did not receive neoadjuvant therapy, which was statistically significant. We also have shown in the previous study that tumor regression grade of the rectal cancers has an improved nodal status, and they also had a non-significant reduction in the number of nodes harvested. It is expected that the number of lymph nodes harvested to go down when you treat patients with neoadjuvant radiotherapy. The nodal harvest of more than 14, most importantly, was reported in about 29% of our stage 2 cancers and 31% of our stage 3 cancers. Looking at studies done on population-based cancer registries, reports from Canada says that only about 22% had more than 12 nodes harvested in their populations. Lymph node harvest is a combined effort of the surgeon and the pathologist, and we have adapted surgical techniques such as skeletonizing of the inferior mesenteric artery, even in surgeries like sigmoid colectomy, where the artery is not ligated, to improve our nodal harvest. A 60% increase in the colorectal cancer burden is expected by year 2030. 2.2 million new cases each year with 1.1 million deaths are expected within the next 10 years. The incidence is increasing in countries with a middle and low human developmental index, and the highest increase in colon cancer is reported from India, according to Wong et al., published in 2021. And USA is seeing the highest decrease in colorectal cancer incidence. Survival from colorectal cancer has also increased globally over time due to screening programs, education in colorectal cancer, improvement in surgical care, and most importantly, improving the adjuvant treatment modalities, which again is lacking in this region of the world. The Eurocare study looked at survival improvement in colorectal cancer and showed that all regions of Europe has improved survival within the last few decades. We looked at 845 colorectal cancers treated at North Colombo up to 2020. We compared the survival of the two groups treated pre and post 2010. 2010 was taken as a year for several reasons. One is that so we have a cohort of patients followed up for a decade to eliminate bias. And also 2010 is around the time where the adjuvant services and the supportive services such as radiology improved remarkably in the country. Pre-2010 included 425 patients, and post-2010 cohort included 289 patients. We looked at overall survival in combined colon and rectal cancers during this period, and there was a significant improvement in patients treated after 2010 in their overall survival. We then looked at rectal and colon cancers separately, and the rectal cancers had a significantly improved disease-free survival treated post-2010 compared to those treated before year 2010. The overall survival also had a significant improvement after 2010 compared to the previous years. When looking at colon cancer, the colon cancer disease-free or overall survival did not show a significant difference. As expected, improvement in adjuvant care and supportive care such as radiology will have a greater impact on management of rectal cancer over colon cancer. Our overall survival rate pre-2010 was 59% compared to 68% post-2010. And if you compare it with the published global data from those years, we are in par with most of those centers. With improvement in survival comes the problems associated with survivors, or what we call survivorship in colorectal cancer. We looked at a cohort of 100 patients who has undergone surgery for colorectal cancer with 65% rectal cancers and 35% colon cancers. We used the short form 36, translated and validated in singular language, to assess their quality of life. And the pattern of quality of life seems to improve within the first 5 to 10 years and going down thereafter. The emotional and the physical component summaries were comparable in these two groups. And more importantly, a majority of Sri Lankan patients had a concern with their organ function, specifically lower GI symptoms. Now, these may be applicable locally based on our diet and the bulky stools that those patients might be experiencing more and more clustering and urgency compared to the populations we see in the West. Ladies and gentlemen, we have attempted to produce a predictive prognostic marker whereby serum albumin was shown to be an effective, freely available, cheap prognostic indicator in rectal cancer. We have described the tumor response pattern in Sri Lankan patients for neoadjuvant chemoradiotherapy and its implications on their survival. We have also implicated the quality of specimens with a minimum nodal harvest applicable to the local population compared to the existing guidelines, and the implications of survival of specimen quality, as well as survival trends over the past 10 years, showing that rectal cancer survival has markedly improved post-2010. Let me take you to the model proposed by Osinkolu and Pagan in the Bulletin of Royal College of Surgeons 2023, assessing sustainability of surgery The 3 Fs are facts, feasibility, and future. Accurate facts will let you assess the feasibility of what you practice, and the feasibility of what you practice currently will decide the future of your practice. The National Cancer Register is the apex body which collects data on all cancers in Sri Lanka. Since its inception in 1980, it has improved in both quality and coverage. One pitfall of this is that they only record incidence and demography and not mortality data. And it has a periodic data collection which can lead to under or over-reporting. Now, to overcome this, the government of Sri Lanka issued a circular in 2012, making it compulsory for all pathology laboratories to report their histologically proven cancers into the National Cancer Control Program. And for the first time in 2017, the NCCP published its data based on the National Pathology-Based Cancer Register. Now, ladies and gentlemen, the same year, the 2017 cancer incidence data for colorectal cancer indicates over 2,600 cancers in that year, compared to the pathology-based cancer register, which reports 1,755. There is a discrepancy of about 30% between those two. The culture of prospective data collection at North Colombo was inculcated in us by Professor Kemal Dean, who established this prospective database for colorectal cancer patients as a manual entry and maintained over the last 25 years. Initially, we had an Excel sheet which gave us numerous problems in extracting data, which has now been developed into a cloud-based database with the RedCap platform. And currently, we have over 1,014 patients as at today. The clinical outcome data from Sri Lanka has been improving. Some of our colleagues from Central and South Colombo have been publishing larger cohorts of prospectively followed data from the local setting. These are very important because these will give you locally applicable data which can be applied in your day-to-day patient management. Vijay Ratna and colleagues in 2020 for the first time published a cohort of surgical patients followed up on a RedCap platform with a cloud-based data management system. These are all highly welcomed improvements in clinical data. Now, although our facts and feasibility are not yet in place, the future is not going to stop throwing us challenges. The future challenges in colorectal cancer care, as I would suggest, are the young cancers, the elderly population, adoption and adaptation of new technologies, local guidelines for screening, molecular profiling, and cancer survivorship. We at North Colombo have looked into some of these. 1 in 6 of our cancers are less than 40 years of age, and 1 in 5 of our cancers are less than 50 years of age. These are alarming numbers. Our colleagues from India has lately reported that maybe 1 in 3 cancers in some of their cohorts might be less than 40 years of age. Do South Asians have a preponderance to develop cancer, colorectal cancer, at a younger age? We have looked at our elderly population, all patients over 70 who have undergone surgery for colorectal cancer. We have shown that their outcomes are not inferior compared to the younger colleagues. If you optimize their cardiac status, you could achieve better results or comparable results to the younger populations. Our population in South Asia is aging, and we will have more and more elderly patients with colorectal cancer coming in the future. We have adopted some of the new technologies at North Colombo. We are using transanal TME, but we have improvised them by using a reservoir bag because we cannot afford a 20,000-pound air seal device. We are using a flexible sigmoidoscope because we cannot afford a second laparoscopic stack inside our theaters. We are using single incision laparoscopy with generous donors, help of the generous donors. And we have tested waters with training modules in robotics. But the question remains, are they feasible in the local setting? Do we need them? We do not have the answers to these questions. A recent study published by the Crocodile Study Group reveals that the median cost of comprehensive colorectal cancer care in India is around $5,300 US per patient. And out of this, $4,300 has to be borne out of the pocket of the patient. These are alarming figures considering a region with countries less than $2,500 US per capita income per annum. Do we need local guidelines for screening? If so, what? The North Colombo data suggests that 77% of our cancers to be in the rectum and rectosigmoid region. Over 85% of our cancers are on the left side. Similar data comes from South Colombo, Bawantagamage, reporting in 2018 that 84% of their cancers are on the left side. Our colleagues from India report that over 80% of their cancers are also on the left side, compared to studies from the US suggesting 50 to 55% of their cancers on the left colon, and a fair proportion of close to 40% of the cancers being on the right side. We need to take this information into consideration when suggesting local screening guidelines. Can we get away with a flexible sigmoidoscopy to detect 80% of our cancers at an early stage? Any screening guidelines that should be developed should take into consideration the local disease pattern as well as the resource availability. We at North Colombo, with prospective data collection, have produced a significant amount of data which can be applicable in the local setting. We encourage prospective data collection to young surgeons and trainees, because if you're a young surgeon who is going to take up clinical research and planning to do retrospective studies, this is what you have to deal with in 2023 in a leading hospital in the western part of Sri Lanka. Chairman, sir, members of the Council of the College of Surgeons and delegates from the SAARC region, may I suggest, to improve surgical quality in this region, let us have a four-pronged plan with clinical research to develop data that is applicable in the local setting, basic science research, which is at its infancy. We saw some encouraging results 2 days ago at the SAARC Oration. Transfer of skills and knowledge that are adapted to match the local resources, and effective data management. And I suggest the College of Surgeons will take the center stage in combining these. And also, ladies and gentlemen, we need to collaborate. In this day and age where science is turning at a very rapid rate, the only way to produce effective and robust data is to collaborate our data. To the delegates from the SAARC region, may I remind you that 8 countries in the SAARC region are home to 1.8 billion population. This is almost 25% of the global population. Imagine the amount of data that we could collect if we collaborate. The SAARC Surgical Society was a brainchild of the Nepalese Society of Surgeons, which came up to light in 1994 at their annual meeting. The Regional Cooperation for South Asian Region was first incepted in the early 1980s as a brainchild of the President Ziaur Rahman of Bangladesh. And the objective of this cooperation was to improve the quality of life of people in South Asia. In 1996, in Kandy, Sri Lanka, Professor Arjuna Luvihari was entrusted with the task of establishing the SAARC Surgical Care Society. And he was inducted the first president in 2002 when the SAARC Surgical Care Society was formally established under the commission of the 7 heads of states at that time. The website says, Sri Lanka has taken a lead role in organizing activities of the SAARC Surgical Care Society, given its neutral geopolitical location and stance. In the presence of delegates and the incoming president of the SAARC Surgical Care Society and the secretary, may I suggest, ladies and gentlemen, let us make Sri Lanka the SAARC Surgical Data Hub so that we could collaborate our data and make a difference in this region. If we can share our problems, we also can share our data and find common solutions for the common problems. We have the know-how, we have the technology, and above all, we have the data. This is not a difficult task for the SAARC. After all, at least one of us have reached the moon. Ladies and gentlemen, let me thank all the patients who participated in these studies, my mentors, teachers, trainers, friends, and family, the clinical staff of the departments of surgery, Department of Pathology and the Data Science Unit at the University of California, the College of Surgeons and its Scientific Committee, and the SAARC Surgical Care Society for giving me this opportunity. Thank you.
Ladies and gentlemen, this concludes the proceedings for the SAARC Surgical Care Society Oration for the year 2023. Let us stand for the exit of the ceremonial procession.